what is defined as ABMR related, what also is not to be considered ABMR histologically speaking, and distinction between acute active, chronic active, and chronic ABMR. Okay, so in the Banff 2019 ABMR classification, we have 4 categories. One is active ABMR, previously known as acute/active, chronic active ABMR, chronic inactive ABMR, and then C4D staining without evidence of rejection, also known as accommodation. But this current classification is limited. It doesn't represent the clinical pathologic spectrum of ABMR. So first, let's cover what is to be defined histologically as ABMR related. And I think when we're looking at these different injury patterns, we need to realize that whatever mechanisms lead to it, that ABMR is essentially an endothelial injury process. So what do we see in the glomeruli? Let's call it acute or subacute. Thrombi certainly is an acute feature that we see histologically. Mesangiolitis may be more subacute. Glomerulitis, especially with neutrophils, was described in the acute ABMR, and enlarged endothelial cells. But remember, we also see these features, some of these features, glomerulitis and reactive endothelium, in chronic active ABMR. Electromicroscopy can help. We see enlarged reactive appearing endothelial cells, loss of fenestration, sometimes subendothelial lucency. You can see here a picture by electromicroscopy with reactive endothelium compared to a normal glomerulus. We can see similar findings in peritubular capillaries by electromicroscopy with enlarged endothelial cells and loss of fenestrations. I've looked at a lot of these biopsies and electromicroscopy, and I can say personally I find it more difficult to evaluate the peritubular capillary endothelial cell injury, maybe because the capillaries are less fenestrated than glomerular endothelial cells, but I find that more difficult. In this particular example, it's pretty obvious though. But we can also see peritubular capillaritis in acute antibody-mediated rejection. But we see peritubular capillaritis, especially with mononuclear cells, in subclinical and chronic ABMR that's C4D negative. For tubulointerstitial changes, in the acute setting, we can see severe acute tubular injury, interstitial edema, and this is in the setting of C4D deposition, otherwise you wouldn't be able to make that diagnosis. And we need to be convinced that acute tubular injury is due to the antibody. For example, C4D should be positive, making sure that it isn't the state of accommodation, for example, in an ABO incompatible transplant. Electromicroscopy can help. We can see these reactive endothelial cells, especially in glomeruli. And there should be no other clinical reason for tubular injury, such as obstruction or some vascular compromise. Vascular changes that we see in acute ABMR, fibrinoid necrosis of arteries, that's the V3 lesion, and then more recently identified the Banff V1 and V2 lesions, but keeping in mind that these V1, V2 lesions can also be seen in T-cell mediated rejection. So let's move on to chronic injury patterns. As we know, we can see transplant glomerulopathy by light microscopy and electron microscopy. This is a case of severe transplant glomerulopathy by electron microscopy, and similar changes in peritubular capillaries with the peritubular capillary basement membrane multilayering. But these cases, as I mentioned before, these chronic changes typically also show the more what has been called active or acute features with reactive endothelium, glomerulitis, and peritubular capillaritis. Now C4D staining, as we know, in the chronic ABMR setting. Oh, and I should say, I was assigned to talk about those with detectable HLA DSA. So just a smaller group of these. But C4D may be negative or focally, multifocally positive or diffusely positive. Overall, we see positive C4D staining in about 20 to 40% of cases of transplant glomerulopathy that are due to chronic antibody rejection. But this rate varies widely depending on your population and biopsy practices. And remember that C4D deposition is associated with higher serum DSA levels and is more likely a more, I think, acute or active rejection compared to C4D negative transplant glomerulopathy. And vascular, chronic vascular injury due to ABMR, we can see transplant arteriopathy with inflammatory cells or just accelerated arteriosclerosis. And the Paris group had described accelerated arteriosclerosis in patients with donor-specific antibody. And they noted that several cases histologically could be indistinguishable from arteriosclerosis due to hypertension. So what is not to be considered ABMR, histologically speaking? Well, we've heard about something, we just heard about it, some from Ian Gibson. But I'll give you some other examples. Here is a case of a young woman who had end-stage kidney disease due to FSGS, and this biopsy was done 1.5 years post-transplant. As you can see here, there's glomerulitis, glomerular basement membrane duplication. Immunofluorescence was negative for immunoglobulins and complement components, including C4D was negative. So what's a clinical history? Well, this patient had developed a PTLD, diffuse large B-cell type. She underwent chemotherapy and autologous stem cell transplantation 6 months prior to this biopsy. No donor-specific antibody. So now that we know the clinical history, the renal transplant biopsy diagnosis is a chronic thrombotic microangiopathy. But we can only say that because not just based on the histology, but also incorporating this clinical history. And Brad Ferris and Dr. Colvin and others published this paper several years ago about overlapping pathways of transplant glomerulopathy. There is transplant glomerulopathy due to chronic antibody rejection, but also hepatitis C infection and thrombotic microangiopathy with significant overlap between hepatitis C infection and thrombotic microangiopathy. Here's another case. Oh, it looks like we have some transplant glomerulopathy pattern by light microscopy with basement membrane duplication, enlarged endothelial cells, and some marginated inflammatory cells. But this was a recurrent immune complex glomerulonephritis. On immunofluorescence, which of course we do when we have abnormal appearing glomeruli, shows staining in this case for IgG and kappa, C1q and C3, negative staining for lambda, and then it's stained for IgG3 only when we did IgG subclass staining. So this is a proliferative glomerulonephritis with monoclonal IgG3 kappa deposits, which is recurrent. And then I'll just mention this other nice study more recently published by the Paris group looking at overlapping causes in biopsy samples presenting CG lesions, so that's a glomerular basement membrane duplication, not considering the diagnosis or the cause of that lesion. And of course, most cases are due to ABMR, but also thrombotic microangiopathy and immune complex glomerulonephritis. So let's move on now to microvascular inflammation and subclinical ABMR. Peritubular capillaries and glomerulitis, as we know, is when we see this margination of the mononuclear cells and neutrophils in glomeruli and peritubular capillaries. So when do we see this? Sometimes in the literature, and as we speak about it, it's referred to as subclinical ABMR. There was this paper from Paris where they had over 1,000 protocol biopsies at 1 year. About 14% had this phenotype of a subclinical ABMR with this microvascular inflammation. A subset were C4D positive, and they had serum HLA DSA at the time of biopsy, they had a lower graft survival rate compared to those without this lesion. Well, we can also see it on 5-year biopsies in a study from Mayo Clinic. Glomerulitis and peritubular capillaritis on protocol biopsies was quite common in positive cross-match transplants compared to ABO incompatible and conventional negative cross-match transplants. So it's quite common on protocol biopsies in patients with HLA DSA or history of HLA DSA. So it's a common finding. It's associated with later development of transplant glomerulopathy, and it is a more indolent lesion. I say that because these patients been seen on protocol biopsies, so they have pretty normal creatinine, so it is a more indolent lesion, but it's still considered an active ABMR in the Banff schema. So what about electromicroscopy changes? There is this nice study from Wavamuno and Brian Nankivell looking at glomerular endothelial injury and glomerular basement membrane changes by electron microscopy on protocol biopsies. A very detailed study where they looked at the endothelial injury patterns, or different types of endothelial injury by electron microscopy in the glomeruli, and these early glomerular basement membrane changes. And you can refer to the paper, but it's a very nice study, detailed study of all these particular electron microscopy features. Again, these may be considered active features, but they're seen on a protocol biopsy and associated with later development of transplant glomerulopathy. So the Banff schema currently doesn't incorporate clinical versus subclinical rejection into the diagnosis. But my question is, should there be a different diagnostic and a different treatment approach for these subclinical versus clinical apparent rejection cases? And should we consider the time post-transplant? And should these be in different Banff diagnostic categories? So let's think about 2 kidney biopsies and assign a Banff diagnosis. Here we have an example of a patient 2 weeks post-transplant, positive cross-match kidney transplant, acute kidney injury clinically, and the biopsy shows thrombi, ATN, and was C40 positive. So this is what? Acute antibody-mediated rejection, right? Or active. Versus this other biopsy, 2 years post-transplant, positive cross-matched kidney transplant, and it's a protocol biopsy. We see glomerulitis, peritubular capillaritis, and the C40 is negative. Well, by the Banff 2019 criteria, this would also be active ABMR. Both of these would be in the same Banff diagnostic category. Should they be in the same diagnostic category? So let's talk about now the distinction between acute/active versus chronic active versus chronic ABMR. But just take a step back and look at different clinical pathologic phenotypes of ABMR. We see this early acute ABMR, we can see it sometimes in patients with preformed donor-specific antibody. And this is a distinct clinical pathologic phenotype. It's within the first month post-transplant. The patients have renal insufficiency. It's associated with high serum DSA levels, and the biopsy shows features such as ATN, thrombi, C40 is positive, I might say always positive. By electron microscopy, there's reactive endothelium, so we know that it is an endothelial injury positive, or it is an endothelial injury process. And usually in these cases, we don't see that much capillaritis, even though it is a more clinically severe phenotype. It's an aggressive form of antibody-mediated rejection, and if not recognized and treated quickly, can lead to allograft loss within days. So there's also a phenotype of later ABMR associated with pre-transplant donor-specific antibody. And this is a situation I described earlier with glomerulitis and peritubular capillaritis on a protocol biopsy, no transplant glomerulopathy or other chronic features. For example, This is a 1-year protocol biopsy, C40 negative from a positive cross-match transplant. So this is the kind of case that may show this pure ABMR histologic phenotype, so we don't see features of T-cell mediated rejection. The patients are taking their immunosuppression, presumably. These patients have a variable clinical course, varying time to development of transplanted glomerulopathy, although this finding is associated with later development of transplant glomerulopathy. It's more indolent than that early acute ABMR. We might call it a smoldering ABMR. So I think it's helpful to think of ABMR on this continuum, and here we're thinking of patients with pre-formed anti-HLA donor-specific antibody. There's a range of this early acute ABMR to acute and active or smoldering ABMR to chronic active ABMR with a particular clinical setting, particular histologic features, C40 and serum DSA levels. But how do we know where to place a biopsy on that spectrum? Well, there are activity and chronicity scores in kidney biopsies in other diseases, such as the NIH lupus nephritis activity and chronicity scoring system. Do we need this kind of score for ABMR cases? I'm not sure we do, but that's my question. I can think of different active or chronic features in ABMR, such as C40 deposition, if it's focal or diffuse or negative, ATN, thrombi, endothelial injury by light microscopy, electromicroscopy, these glomerular basement membrane changes by EM, capillaritis, DSA level, which of course is a clinical or lab feature, transplant glomerulopathy, peritubular capillary basement membrane multilayering, possible interstitial fibrosis and tubular atrophy. Could there be a molecular classifier also to put a biopsy in a particular category, or to be able to understand how active it is, or how active it is if it shows chronic features or if it doesn't show chronic features? So what about transplant glomerulopathy? Currently, the Banff schema lumps all of transplant glomerulopathy into one category, but as we know, not all TG cases behave the same. For example, C40 positive TG behaves differently, has a worse prognosis compared to C40 negative transplant glomerulopathy. And there was this study from the Paris group looking at a different archetypes classification for TG, looking not just at C40, but also clinical and other histologic features. And by this analysis, they place patients with transplant glomerulopathy into different prognostic or outcomes groups. Now, what about this Banff category of chronic inactive ABMR? Is this a useful category in the Banff schema? Do these cases exist? I'm not sure if they do. I think essentially all cases of transplant glomerulopathy that I see show some reactive endothelial cells. Maybe someone will develop a really good drug, and we will have a chronic inactive ABMR, but right now I'm not sure if this category exists. And then there's one more clinical pathologic phenotype that seems to be a little bit different, and that's a later ABMR associated with de novo DSA, combined, often shows combined active and chronic ABMR features along with TCMR features, T-cell mediated rejection features. So here we can see a biopsy from a young woman. The creatinine actually was normal, 0.8. It's a 1-year protocol biopsy. The previous kidney transplant failed due to rejection, and she has de novo DSA. We can see tubulitis here and interstitial inflammation. The glomeruli showed glomerulitis, and the C40 was positive. So this is an example of combined antibody rejection and T-cell mediated rejection in the clinical setting of de novo DSA and medication non-adherence in this particular case, but also could just be under immunosuppression. For example, if someone had infections and then could not have their adequate immunosuppression. So where do we we go from here, I think we just need to recognize that the Banff system doesn't currently account for this full spectrum of ABMR, and there are clinical implications for giving the same name to different clinical pathologic entities. And I think we should recognize at least these particular types of ABMR biopsy phenotypes, the early acute ABMR with preformed DSA, later ABMR with preformed DSA recognizing the histologic spectrum, ranging from more active to more chronic, and then later combined ABMR and T-cell mediated rejection, usually associated with de novo DSA and under immunosuppression. And I'll just put in a plug for our highly sensitized or antibody-mediated injury working group that we need a common language to refer to these different rejection processes. This is one goal of our working group. And I'll just mention what Carrie Shinstock said yesterday, that this lack of a common language, it's not a Banff problem, it's a problem overall in transplant. But it's something that I think we should address, or at least recognize that we don't have a common knowledge or a common language. Thank you.
Thank you, Lynn. Perhaps we can now move to the discussion about all your questions, because you asked questions. It's almost time to end the session, but of course we do not want to end the session, so I think it's for those people who are really wanting to leave, just leave, I would say. For the others who are interested in staying for another hour, just stay. Lynn, so you asked two questions, at least the one that I remember. The first one is, do we need to differentiate the subclinical ABMR from the clinical ABMR? We do not have a survey on that, but anybody who can comment on that question? Go first, Michael, and then
So I think the data we have from Paris and also from your center about subclinical AMR, it takes the same natural course towards TG and failure, right? So why would we then try to segregate it out other than the clinician knowing, okay, it's a stable function, but the pathology is the same? Why would we need to do this, is my question. And the other where you said is the Banff system doesn't allow to capture all these phenotypes. I think it does when you look at the lesions. The diagnostic categories probably not. So is the question, are you proposing we should have chronic active ABMR class 1, which is early, or use subgroups in these diagnostic categories, or is it enough that we try to educate our clinicians to read the lesion scores, right, which tell you, together with date of transplant and the lesion scores, they tell you what you described from my perspective.
Very nice talk there, Ajay. I actually agree with Michael that instead of creating more diagnostic factors, we should spend more time educating the clinicians that each one of the diagnostic categories is a very wide factor. We could also create many categories into BMR. So what we really need are more nuanced treatment recommendations from our clinical categories, from our clinical bodies. That this diagnosis has this wide spectrum of clinical presentation. Please take those into account while managing. They know it's something, they know it's something, they know it's late. And I don't think we can define them very in a non-overlapping manner, and we shouldn't even try to do that. So that's my opinion.
Yeah, I just want to clarify, I'm not proposing more more scoring by pathologists. I don't like the lupus scoring system, for example. But I think it is, like, I agree. I think it's important just to recognize that there's ABMR, and then, you know, recognize that there are different phenotypes of it and that it is a spectrum. But sometimes it, you know, it puts pathologists in an awkward position because some centers have a protocol. Oh, we need to treat this patient with plasmapheresis and IVIG if the G plus PTC is 2 or greater. You know, and then it puts us in this situation like, oh, we just based on our grade, they're going to treat this. I mean, not at our center, but But just recognize that it has those implications when we call it active.
I think that you are actually proposing a different approach to this situation that you described as compared to other situations. You can take several patients with TCMR that have very different clinical presentation, and we're not proposing to call them otherwise just because of that. So I think that number one, it would complicate our life enormously. Number two, it would limit the communication of clinicians because it wouldn't be transparent and clear anymore, and it is quite complicated already. Number three, you introduce the recognition DSA status, which is not known at the time of biopsy recognition, or it's never known, because not all centers perform this testing. So on one hand, I think that we should differentiate two different things. One is that there is much bigger granularity of ABMRs that Banff system has been recognizing by calling it this name or other name, but it is not enough to introduce at this time, as we are now, new categories. This is my impression now.
Yeah, I don't know if I have anything else to add. I agree. I think defining clinical versus subclinical, even for a clinician, can be difficult at times because sometimes it's slowly progressing. And take comfort. Don't worry about what we do. If we make a mistake or do the wrong thing, that's on us. So I think it's okay to call it the way it is and don't worry about what people are going to do, even if it's not what you agree.
So two things. First, I agree with just about everything that's been said. But first, we have to recognize that Banff, as it now stands, is a diagnostic schema, not a prognostic schema like the ISN RPS classification for lupus nephritis. I actually tend to be a fan of activity and chronicity indices. And if I do it in all my lupus nephritis reports for 20 years. And if it helps the clinician, I'll be happy to put it in. But I think the last thing that the Banff schema needs at this point is more complexity within the actual diagnostic criteria for any kind of rejection, as your group survey certainly showed. So I think we should leave the diagnostic criteria alone unless there are diagnostic elements in the current criteria that may actually be incorrect. And I think there is one right now that's in the ABMR classification that is incorrect, and that is that the use of the molecular classifiers as a surrogate marker for DSA. I think the work of a lot of people has shown that this is a downstream event and not dependent on DSA, and I would remove that.
Thank you. Building on what Mark just said, are you aware of centers using the suggestion that was made in the last classification of, I don't know, chronic active ABMR with mild activity and moderate chronicity? Are you aware of centers using that and of the differentiated reaction of the clinicians on such reports?
No, I think it's the opposite. They're not using it, they're confused by it. That's what the survey shows. Right?
I think that Nico is touching a very important point. We can be very, very granular and then try to categorize, but as a clinician, we try to make the big picture, and unfortunately, it's not so that we have trials that say that for this subtype of a subclass, we have treatment A, and for another subclass we have treatment B. We actually do not have good treatments for DSA positive ABMR, so actually we just start trying a bit. So the more granular you go, it does not help us that much. On the other hand, what is really helpful is to get a good idea of the disease activity. And I follow what Mark is saying a lot. If we could get a good view on the activity, and for that I look at the Banff scores, I discuss the biopsy with the pathologist to see how many inflammatory cells do you see. The chronicity is equally important. If it's really chronic without much activity, we tend to not over-treat the patient because these are very toxic. And the actual Banff category that the patient is in is not the thing that at least I am not considering that much if it's chronic active versus chronic with a little bit of inflammation just below the activity. This is not my clinical decision making. Perhaps
I'll just say, also to answer the other question, that I'm actually in favor of making it more simplified. And if I have a case that shows, capillaritis and there's no transloculopathy, I say, capillaritis or whatever, or whatever, consistent with antibody rejection. I don't say active or anything like that. I just say consistent with antibody rejection. And then in terms of grading too, at least acute ABMR, I disagree with calling it as a grade, grade 1, 2, or 3. Because I think that implies a particular severity that we shouldn't be implying based on the biopsy. So I'm actually in favor of, simplifying everything and not subdividing it.
Yeah, so I somewhat disagree with the previous speaker. I think we should include clinical data into the category because the idea of a diagnostic system is to make a diagnosis, okay? And for the diagnosis, you need the information that it's an early acute rejection, and this is a different disease compared to a chronic active or chronic ABMR in de novo patients 10 years after transplantation. So I think the diagnostic criteria should reflect or should make this diagnosis. And so I think, and this is kind of along the lines with the paper by Kerry Shinstock and the TTS working group, and we met at this time that we have, and as you pointed out, you say there's different diseases, and I think, Jim, this should be reflected by a diagnostic system.
Can I make one more quick comment? Just one more quick comment. I would encourage nephrologists to actually look at biopsies. Biopsies with the same scores can look very different in the microscope. For example, IQ can be 26% or 49%.
Look, guys, we're over here trying to get this conversation.
I have only one microphone.
I know.
I thought with what is first. I don't know how long we can have this. Because we also have to discuss the DSA negative counterpart.
I try to keep it short. I'm echoing what you just said. I disagree with what Clemens was saying. I think that if we need to keep it short, what we really need to make a diagnosis that will inform us and help us to decide the treatment is, yes, is it active? Not only if it's active, what is the mechanism? Because this will help us to define what we're going to do. I don't think that there are that many different types of antibody-mediated rejection. I don't think that early or late is important. What is important is whether it's complement dependent or not. Unfortunately, the C4D is not really helpful, it's not really efficient. If we had a good way of knowing whether it's complement dependent or just ADCC, then we would know that for complement we need IBRGs, plasmapheresis, maybe something else. And for the rest, unfortunately for now, we have nothing to do. And I tend to say that on the graph that you've shown, I would drop the two first because they are probably complement dependent because they are C4D, you have high MFI, and the other two, they're probably ADCC dependent.
Was it first? I really.
But I guess this is my 2 cents on it from people that have a kidney transplant, right? So if you do use a classification system, maybe that could be used as a way to spur innovation. Is in terms of if you don't have really the treatments right now, right? What's the benefit of bringing this issue, creating a burden? But if you could use it as a way to help make the case to get trials and build upon some momentum right now, I guess I would just ask you to consider that perspective because that's what's needed, right? And that's still the problem, long-term outcomes. So I just want to make sure it's linked back to patient care and something that can potentially help bring innovation. I'll make that clear. Thanks.
I see last hands waving at me. Hopefully not starting again in a completely different discussion.
Let's go. Well, I think Lynn just pointed something out that I think we kind of passed right by that, but right now we have type 1, type 2, type 3 antibody-mediated rejection according to the classification. I think that too should maybe be omitted, and that indeed we do hold on to what we did improve in the last classification, is that it being active or chronic, and the grade of that, so mild, moderate, severe. And I think maybe, but I'm not a clinician in that sense, it might be more illustrative of what we see in the biopsy. Because now too, we constantly have to discuss what do we see in the biopsy face to face. Indeed, if you do take your report and you go from New York to LA, you want to be able to say, look, the pathologist said it's severe, active, mild chronic, antibody-mediated rejection, C4D negative. So that gives an insight on what we see in the biopsy. Mark?
So in response to your comment, one thing that was proposed at the ASN committee meeting is to actually have a discussion section led by one nephrologist and one pathologist. This is not regarding transplant. This is regarding native kidney biopsies, but it could be easily applied to transplant as well. It's very easy for, I don't know, maybe I'm overstating, but for someone like Carrie to march down the hall and review a biopsy with Lynn. And for people who focus exclusively on transplant nephrology to understand the Banff lingo and what this means. But for nephrologists who don't treat massive amounts of transplant patients, the issue of understanding the meaning of the biopsy report is important. Just like nephrologists in community practice who might do 20 or 30 biopsies a year and want to know should they give a patient with IgA nephropathy steroids, it's important that they understand the biopsy report. So what this ASN initiative is actually to have one leader who's a pathologist, one leader who's a nephrologist, and try to get at what the nephrologists want, what the information they consider important for treating the patient in the biopsy report. And maybe this should be a Banff initiative too. Do they want simplicity? Do they want granularity? Do they want more in the diagnosis line, or do they want Banff lesion scores? Do they want an explanation of what the Banff lesion scores are? All of this could be considered, but again, in the context of saying that the Banff is a diagnostic criteria, not a prognostic criteria. And adding prognostic information, while it might be helpful, is not the diagnosis line.
Is there any other comment on DSA positive, ABMR, and because we will try to summarize everything I was said, and in the Banff report, I believe that the idea is currently to not have this published as soon as possible, but really ask as many people who are involved in the field to contribute or at least comment on it. So we'll see how that goes. But if there's no other comments, I think I can have the last presentation. I'm happy to say that it's not real presentation. I just prepared a few slides for the discussion. So thank you so much, Lynn.